The whole concept of immunotherapy in colorectal in cancer overall is very exciting, of course, but in colorectal cancer has been gaining steam. So when we look at metastatic colorectal cancer now, we can split them into the 96% versus the 4%. The 4% are the microsatellite unstable, so the microsatellite instability high tumors, those that have some loss of mismatched protein defects, and those seem to actually respond incredibly well to immune therapies such as PD-1, PD-L1 inhibitors. The reason for that is those tumors with these protein defects end up being loaded with mutations, so they hypermutated, and so they are just ready to explode in face of the immune receptor. So those patients with those tumors actually end up having very significant responses to single-agent immune therapies. And then we're left with the 96% of the patients, and that's the space we want to talk about more. So those patients, when you look at the immune therapy studies, the PD-1, PD-L1, single agent, whether from the initial studies or follow-up studies, they don't seem to respond to immune therapies. So the question is why? Well, one, they don't have the mutational load. Two, they don't have an immune-rich microenvironment. Those T cells are not available around the tumor cells to allow the PD-1 inhibitors and the PD-L1 inhibitors to actually have their effect. So there are ways to manipulate the immune system. One way that's now in the clinic in actually phase 3 is to apply a MEK inhibitor along with the PD-1 inhibitors. What the MEK inhibitor does, it upregulates those CD8 T cells, so those tumor infiltrating lymphocytes, into the tumor, and so when you give the PD-1, you see responses.